All right, let's get straight into it. We're breaking down the new KDIGO 2026 guideline for anemia and CKD. The goal here is to deliver the high-yield, practice-changing recommendations you can apply immediately in your clinical workflow.
So here's our roadmap. We'll start with the big shifts in nomenclature and the new hierarchy for HIF-PHIs. Then we'll cover diagnosis and the specific iron therapy thresholds, dive into the protocols for ESAs as first-line treatment, clarify the role and contraindications for HIF-PHIs, tackle treatment hyporesponsiveness, and finally, wrap it all up with the integrated clinical algorithms.
Okay, first up, the core changes from the 2012 guideline. There are two major updates right off the bat: a significant revision to how we describe iron deficiency, and a much more definitive positioning for the HIF-PIs in our treatment algorithm.
The new terminology is all about being more precise with the pathophysiology. So absolute iron deficiency is out. We're now calling it systemic iron deficiency, which better reflects depleted total body iron stores. And the really critical one, functional iron deficiency, is now termed iron-restricted erythropoiesis. This is a much better description, isn't it? It perfectly captures that state where iron stores are adequate but are functionally trapped and unavailable for erythropoiesis, often due to the high hepcidin levels we see in CKD-related inflammation.
This brings us to probably the single most important therapeutic update. Recommendation 3.1.1 is clear. Erythropoiesis-stimulating agents, or ESAs, are now firmly suggested as first-line treatment over HIF-PHIs. And why is that? It really comes down to the data. We have extensive long-term safety and efficacy data for ESAs. This is in stark contrast to the ongoing uncertainty around the long-term risk profile of HIF-PHIs, especially concerning major adverse cardiovascular events and vascular access thrombosis that have been noted in some trials.
All right, moving on. Let's get into the nitty-gritty of diagnosis and the updated criteria for when to start iron supplementation. This section gives us some very direct, actionable thresholds for clinical practice.
Okay, so here's the diagnostic pathway. You start with the basics: a CBC, reticulocytes, ferritin, and a TSAT for all your CKD patients, G1 through G5, hemodialysis, or kidney transplant recipients. Once you've diagnosed anemia using standard WHO hemoglobin thresholds, the next step is to evaluate for iron deficiency using the new specific cutoffs. Now, here's a key practice point. If you see a ferritin less than 45 ng per milliliter, that's a major red flag for severe iron deficiency, and it mandates a clinical investigation for an active source of blood loss.
And here are those core data-driven thresholds for initiating iron therapy. It's really important to distinguish between populations. For your hemodialysis patients, the trigger is a ferritin of 500 ng per ml or less and a TSAT of 30% or less. Pretty straightforward. But for your non-dialysis and peritoneal dialysis patients, it's a bit more stratified. You'll initiate iron if ferritin is less than 100 with a TSAT less than 40%, or if the ferritin is between 100 and 300, but the TSAT has dropped to less than 25%. The logic here is to replete iron stores before starting an ESA.
So what about the route of administration, oral versus IV? The guideline makes a very clear distinction. For your CKD G5 hemodialysis population, the suggestion is to use intravenous iron. It's simply more effective, and it reduces pill burden. In contrast, for non-dialysis and peritoneal dialysis patients, the choice between oral and IV is a matter of shared decision-making. You have to balance patient preference, the severity of the deficiency, tolerability, and of course, cost.
Okay, let's focus now on ESAs. Since they're confirmed as first-line agents, we need to be crystal clear on the protocol, when to start, and just as critically, what our maintenance targets are.
For patients on dialysis, recommendation 3.2.1 is explicit. Initiate ESA therapy when the hemoglobin concentration falls into the range of 9.0 to 10.0 grams per deciliter. While for non-dialysis patients, the decision is more individualized based on symptoms, this 9 to 10 gram per deciliter window is the key anchor for the dialysis cohort. And this is absolutely critical. We have a level 1 recommendation establishing a hard safety ceiling for hemoglobin. Do not target a level above 11.5 grams per deciliter. This is reinforced by data from pivotal trials like CHOIR and TREAT, which demonstrated an increased risk of stroke and major adverse cardiovascular events when targeting higher hemoglobin levels, without a significant payoff in quality of life. So 11.5 is the ceiling. All right, so if ESAs are first line, where do the HIF-PHIs fit in? This next section gives us a very precise definition of their limited, second-line role in this new therapeutic landscape.
The bottom line is that HIF-PHIs are positioned strictly as an alternative therapy. Their use should be considered in specific clinical scenarios. For patients who have a strong preference for an oral agent after being fully informed of the risk profile, those with a documented intolerance to ESAs, or as a therapeutic trial in cases of established ESA hyperresponsiveness.
And then we have the absolute contraindications. Practice point 3.7.5 is very clear here. You do not use HIF-PEs in patients with an active malignancy, a recent cardiovascular event like an MI or stroke, or a recent venous thromboembolism like a DVT or PE, or a recent vascular access thrombosis. These are non-negotiable exclusions. Okay, let's talk about a scenario we all face in the clinic: ESA hyporesponsiveness. This can be a really challenging problem, and the good news is the guideline now provides a clear, stepwise algorithm to manage it. So the structured approach to hyporesponsiveness begins with identifying and treating reversible causes, like iron deficiency or inflammation. If that doesn't work, or if no clear cause is found, the algorithm bifurcates. For mild asymptomatic anemia, observation is appropriate. However, and this is the key decision point, if transfusions are required or symptoms are present, you can consider a limited 3 to 4 month trial of a HIF-PHI. And if there's no meaningful response in that timeframe, therapy must be discontinued.
To conclude, let's synthesize all this information. We'll quickly review the integrated management algorithms for distinct CKD populations, which really shows how these recommendations flow together in practice.
For the hemodialysis population, the pathway is clear. Screen, then initiate IV iron based on the ferritin less than 500 and TSAT less than 30 thresholds. ESAs are first line, initiated at a hemoglobin of 9 to 10 grams per deciliter with a strict maintenance ceiling below 11.5. HIF-PHIs are reserved as an alternative with careful attention to contraindication. Now, for non-dialysis CKD patients, the iron thresholds are lower and the choice of iron route is flexible. ESA initiation is driven more by individual symptoms, typically considered when hemoglobin falls below 10 grams per deciliter, and it's administered subcutaneously. The maintenance ceiling of less than 11.5 grams per deciliter remains absolute.
For patients on peritoneal dialysis, think of them as a hybrid. Their iron management, both thresholds and route, mirrors that of the non-dialysis population. However, their ESA initiation threshold aligns with the hemodialysis cohort at 9 to 10 grams per deciliter. The administration route is subcutaneous, and the maintenance target is consistently below 11.5 grams per deciliter.
This leaves us with a critical question for clinical practice. In that common scenario of high inflammation, presenting as iron-restricted erythropoiesis with an elevated ferritin but low TSAT, how will you apply these guidelines to balance the need for iron to facilitate erythropoiesis against the theoretical risks of iron overload and infection? This remains a key area for nuanced clinical judgment.